So good morning, everyone. Let me introduce my 15-month progress of my PhD thesis titled Impact of New Genomic Technologies on Patient Care. My name is Barbara Csendes. I'm a medical doctor specialized in clinical genetics. I work at the Institute of Genomic Medicine and Rare Disorders. My vision is to boost the effective utilization of genomic technologies, and my mission is to recommend, develop, and support educational and financial policies. To achieve that, we need to explore the different aspects of approved treatments in spinal muscular atrophy. My first project is investigating the functional ability of patients before and after Spinraza treatment in spinal muscular atrophy. Spinal muscular atrophy, SMA, is a progressive hereditary neuromuscular disorder results from the loss of the SMN1 gene, which leads to a severe muscle weakness and atrophy. Without adequate treatment, it can be lethal under age of 2. So no wonder it is the most common genetic cause of infant mortality, with an incidence of approximately 1 in 10,000 live births. Fortunately, within the last few years, 2 disease-modifying therapies, Spinraza and Evrysdi, and 1 gene therapy, Zolgensma, have been approved for use in SMA. Within our initial study, we were exclusively concentrated on Spinraza, as a significant amount of eligible data is only accessible for this medication. Approved in 2016, Spinraza became the first therapy in SMA. Administered via intrathecal injection, it is a lifelong and extremely high-cost therapy. SMA can be divided based on the onset of the disease and the severity of the symptoms. Alternatively, SMA can be divided based on the functional abilities of the patient at their time of their diagnosis, namely non-sitters, sitters, and walkers. Previous meta-analyses used the traditional classification. However, we would apply the aforementioned groups because correlates better with the outcomes to be examined and that reflects the variability and therapeutic response in a more efficient way. So our aim is to investigate the effectiveness of Spinraza in patients with SMA with different functional abilities. Which leads to our question, how the functional ability of the patients with SMA influence the effectiveness of Spinraza? To answer our question, we set up a PICO framework. Our population is non-sitter, sitter, and walker patients. Our intervention is after Spinraza treatment. Our comparator is before Spinraza treatment. And we would like to measure effectiveness and safety. Our hypothesis is that the clinical effectiveness of Spinraza significantly depends on the functional abilities of the patient at their, with SMA, which leads to our clinical implication. With our study, we need to highlight, to classify and treat the patients according to their functional abilities. We conducted our systematic search in 3 databases. Here you can see the finalized search key for that. After the selection process, we ended up 14 eligible full text. We analyzed all of our planned outcomes, so let me introduce the results of these. On the first forest plot, you can see the 1-year change in motor function based on the Hammersmith Functional Motor Scale. This scale assesses the patient's ability to perform various activities. Total score ranging from 0 to 66, where 66 means that the patient's functional ability resembles that of a healthy person, and 0 indicates poor motor condition or inability to perform any activities. For the statistical analysis, we used mean difference. In the walker subgroup, the mean difference was 2.88, and in the sitter subgroup, the mean difference was 2.70. Although the effect of Spinraza is small, it is clinically relevant for the patients. Another noteworthy conclusion is that the functional ability does not impact the drug's effectiveness. On the next forest plot, you can see the 2-year change in motor function based on the same Hammersmith Functional Motor Scale. As you can see, in the sitter subgroup, the mean difference was 1.39. Compared to the 1-year results, a slight decrease can be observed, which can be expected due to the natural course of the disease. Moving on to my third forest plot, you can see the 1-year change in motor function based on the revised upper limb module. This scale assesses the patient's ability in the upper limb total score ranging from 0 to 37, where 37 means that the patient's functional ability resembles that of a healthy person, and 0 indicates no upper limb function. For the statistical analysis, once again, we used mean difference. In the Walker subgroup, the mean difference was 0.43, which is not clinically relevant, and in the Sitter subgroup, the mean difference was 1.06, which indicates mathematical and clinical significance. Although a 1-point change might seem irrelevant, for a patient it means that they are able to raise a cup to their mouth. Without any treatment, the patient's condition would deteriorate, so any improvement is considered as a success. Of course, our study has a strength and limitation. One of our strengths is the detailed subgroup analysis regarding the non-sitter, sitter, and Walker subdivision. On the other hand, this is our limitation as well, because due to the different classification in previous studies, unfortunately, not all data can be assessed. Based on our results, we can conclude that Spinraza has proven to be efficient in the sitter and Walker subgroup, so therefore clinician can indicate Spinraza therapy for sitter and Walker SMA patients. Future research should apply the alternative classification more widely. Here you can see the progress of my first project. We are basically ready to send the manuscript to internal review. Moving on to my second project, which is investigating the effect of approved treatments for spinal muscular atrophy on the patient's healthcare needs. Before the era of disease-modifying therapy, best supportive care was the gold standard for spinal muscular atrophy. It is a comprehensive approach that aims to address the various aspects of the condition. The key elements are nutritional and respiratory support, orthopedic care, and rehabilitative services. I already introduced to you the approved treatments, Spinraza, Evrysdi, and Zolgensma. It is important that treatments must be provided alongside the best supportive care. The healthcare needs of SMA patients include individualized supportive, rehabilitative, and palliative care, which comes with a substantial cost. Unfortunately, there is a limited information of healthcare resources utilization. However, it would be essential for adequately designing public policies and funding decisions. So therefore, our aim is to investigate the effect of the addition of Spinraza, Evrysdi, and Zolgensma on healthcare needs compared to the best supportive care. Which leads to our question, how does the addition of Spinraza, Evrysdi, or Zolgensma influence the healthcare needs compared to the supportive care only? To answer our question, we set up a PICO framework once again. We would like to compare best supportive care and each and every approved treatment to best supportive care only. And we would like to measure the healthcare needs of SMA patient. Our hypothesis is that the addition of Spinraza, Evrysdi, or Zolgensma significantly reduce the healthcare needs compared to the best supportive care only. And hopefully, my two projects will contribute to address the different dimension of treatment impact and allow me to finish my presentation with Peter Drucker's words, the best way to predict the future is to create it. Thank you so much for your attention.
Congratulations. I would have one question. You highlighted the pros of Spinraza, but were there any adverse events of the usage of Spinraza?
Thank you so much for your question. There were no serious adverse events, fortunately, just some mild ones. Basically, all of them are related to the intrathecal injection itself. So basically, back pain, headache, nausea, vomiting. These were the most frequent ones.
Thank you.
Thank you.
Just one short question. Do you have literature data on that? What is the average time from diagnosis to treatment? And are there differences between the countries? What is the usual average time from diagnosis to treatment?
So nowadays, here in Hungary, pre-symptomatic screening are available. So basically, we can screen right away the children or the infants in the pre-symptomatic stages. So it is very fast. But before that, I think it is a well-rounded and well-defined disease. So almost every clinician, when I see a baby with muscle weakness, that's the first thing that came up, basically SMA. So that's we have to rule out. That's the first thing we have to rule out, SMA. So therefore, I think you have a really short answer or diagnosis time.
Okay, and what about Europe? Is in every country the screening available? And what about worldwide?
I mean, not every country have this opportunity, like here in Hungary, but more and more, fortunately, more and more country have this opportunity to do that.